When people say this can't be a stroke because the CT is negative, me as a neurologist, I'm always like, no, wait.
Welcome back to PedsCrit. I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
We are here today with Dr. Ilyse Genser to talk about neuroimaging. Ilyse, can you introduce yourself and tell our listeners something you enjoy outside of medicine?
Sure. So my name is Ilyse Genser. I am a child neurologist at Children's National Hospital. I'm also the associate program director of our fellowship as well. I am originally from New York and then went to Rhode Island to do my peds training and then came to DC to do my child neurology training, and I'm attending there now. Something I like outside of the hospital is eating and finding new ice cream places. Probably my number one passion, just above neurology.
Just above.
It's wonderful to have you. On PedsCrit, we love talking about core and controversial topics in pediatric critical care medicine. This, I think, is going to file under the core topics, neuroimaging for the pediatric intensivist. Before we jump to the conversation, any conflicts of interest to disclose?
Nope, none.
Wonderful. Alice, shall I give us our first case?
Let's do it.
All right, so you're in the PICU. You have a 2-month-old infant who's intubated and sedated, initially came in with RSV and superimposed pneumonia. Unfortunately, she developed sepsis and severe DIC with coagulopathy and thrombocytopenia. On the 3rd day of ICU admission, she's noted to have decreased spontaneous movement and is not moving her right side as much as compared to the left. You're worried about some kind of intracranial pathology and even a possible hemorrhage. So get things started. Think broad overview here. What are the general neuroimaging techniques that we should consider for this patient?
Yeah, I think with this patient being a 2-month-old infant, one of the first things we sometimes think about is a head ultrasound. And so that is going to be an easy technique without any radiation exposure and is easy to do with babies who have an open fontanelle. So should be something considered in neonates with open fontanelles. Other options to consider are a CT scan, usually pretty common first line of imaging that's usually pretty quick and easy to get without needing sedation in kids, or an MRI scan. That one's sometimes a little bit more tough logistically, both from the availability at your institution, whether it's, timing, is this the middle of the night? Some places like our institution does not have MRI capabilities overnight. While an MRI is very sensitive for a lot of different things, oftentimes that's not going to be the option that you're pulling for in an acute situation. And I think CT head or a head ultrasound are probably more practical and available techniques in most places.
Can you tell us more about head ultrasound in this patient?
Sure. So head ultrasounds, usually used in neonates, can really be used in anyone with an open fontanelle, but as the fontanelle starts to close, so usually most people's fontanelles are closed around 12 months, but as the fontanelle starts to get smaller, somewhere around 8 months, it starts to get harder and harder to get images through the anterior fontanelle. But at 2 months, you should be able to get a pretty good image. Depends on where you are, but most imaging techniques consist of having ultrasound transducer through the anterior fontanelle, as well as the mastoid window and the posterior fontanelle. The posterior fontanelle closes pretty early, in the first few months. And so that can be a hard one to get in kids around this age, 2 or 3 months. But you're really trying to get imaging both from the anterior and the posterior aspects to try and image the anterior and posterior parts of the brain.
Do you feel like after that posterior fontanelle closes, the effectiveness or the sensitivity, specificity of a head ultrasound changes? Or do you kind of see it the same way as long as you at least get one good view through the anterior fontanelle?
I think it's pretty similar. I think in general, head ultrasounds are not great at visualizing the posterior fossa. So if you're worried about pathology in the cerebellar area or the posterior fossa, it's not your best imaging technique. And so, yes, a head ultrasound will be good at looking for really large hemorrhages, usually more in the anterior parts of the brain, or large ischemic changes or midline shift. If you're really looking for more subtle changes, especially in the posterior fossa, your head ultrasound is probably not going to be your best technique for visualizing those things.
I think that's a great learning point already. If you're worried about pathology in the posterior fossa or cerebellar area, a head ultrasound probably isn't the right study for you. You already mentioned it can be effective for detecting hemorrhage, especially kind of towards the cortex of the brain. Will you tell us more about how effective it is? If we don't see a hemorrhage, how reassured can we be? Can it characterize the severity? Tell us more.
Yeah, so I think the important thing also about head ultrasound is you're looking at echogenicities. And so you might see something that is bright on a head ultrasound, but it can't really differentiate between an ischemic and a hemorrhagic stroke. So you might see something that's bright, But the question, especially for someone in DIC, or if you have a patient, who's on anticoagulation and the question, or ECMO, and the question is, do we need to change our anticoagulation strategy? You probably can't definitively make that decision based on a head ultrasound. What you could do is use it as kind of a screening tool and see, do I see something that's bright on this? And then usually we follow up with a head CT, which is a little more sensitive for determining ischemia versus hemorrhage. So I think that's an important point, is you might see the echogenicity, but it's hard to tell what that is specifically on head ultrasound. I think head ultrasound is good at ruling out really big hemorrhages or really big pathology. But as far as smaller hemorrhages, smaller bleeds, I wouldn't say that you can 100% rule them out with a head ultrasound.
And also about changing your management too, right? I think every neurosurgery group has a slightly different threshold to intervene, different conversations you have. And then certainly a patient on ECMO, you would need to know about a posterior fossa bleed if there was a neuro change.
Yeah, and we tend to use in our cardiac ICU, we tend to use head ultrasound as a screening tool. Post-operatively, after kids go to the operating room, they'll do a head ultrasound. Or if kids are on ECMO, we'll do head ultrasounds for a certain number of days in the week. And so it's a good screening tool to say, am I seeing something that is big and is new and is changing? But oftentimes, if we do see something that is an echogenicity, we follow it up with a head CT and try and really delineate what specifically that change is. So I think in my world, I tend to use it as a good screening tool. But if your clinical suspicion is high, I think following up with more specific imaging is probably a safer way to go, especially if you're going to make management decisions based on it.
I feel like we probably all have the most familiarity with using head ultrasound to screen for hemorrhage. Is there any other key clinical application that we use head ultrasound for commonly?
I think hemorrhage and ischemia are probably the two most common ones. You can also use a little bit different than head ultrasound, but you can do transcranial Dopplers as well. And that is really looking for vasospasm or changes in the vessels. And so that can be actually a really important diagnostic tool in people who have things like subarachnoid hemorrhages, where they're at risk for having delayed vasoconstriction and ischemia. And you can use that as a screening tool when they're in the ICU. But those are probably the main indications in which we use kind of ultrasound-based imaging in kind of the neurology world.
So what advantages, we talked a little bit about the posterior fossa stuff. What are the advantages, but then also what are the specific limitations of CT for this case?
Yeah, so I think CT is going to be very sensitive at detecting acute hemorrhage. So even hyperacute hemorrhages that just happened, they're going to be very sensitive at detecting that. You also would be able to look for things like herniation. So someone with acute weakness and someone who's critically ill, you obviously would be wanting to know if there was concern for edema and herniation. CTs are also really good at detecting hydrocephalus, so increase in ventricular size, which you can tell on head ultrasound, but again, gives you a more detailed picture when you're doing head CT. Limitations of head CT. So the obvious thing we always think about in children is radiation exposure. I don't want people to be fearful of doing CTs on children if you need to. The risks are fairly low if you're not getting, again, repeated head CTs very frequently over time. But I think in the ICU, if you think your patient needs a head CT, don't shy away from getting them a head CT. Other limitations besides radiation are also some institutions like ours have access to portable head CTs. The quality is a little bit lower in that scenario. But for a patient like this, you would also have to think, are they stable to be transported to the CT scanner? Because that is also a big limitation versus a head ultrasound, which you can actually do at the bedside as a screening tool. So I think that's also a consideration. What is your patient stable to get to from an imaging standpoint?
Something I learned this year is that not all portable scanners are the same. You could bring the one from the operating room and then to get close to the bed, it's like a positioning thing versus a donut that can come right up, which was interesting.
I feel like when deciding to do an emergent head CT for a patient that you're worried about intracranial pathology is a good example of a procedure or an imaging study that has some risk with radiation, but we're tasked with having a nuanced conversation with the family in a crisis mode. Do you have any tips or different techniques that you use to communicate this risk of exposure to radiation versus risk of underdiagnosis so you can help parents understand that?
Yeah, and I think whenever you say the word radiation with a CT scan, parents often get freaked out because they think about the long-term risks. And again, with children, that we should be thinking about their lifespan that, in a baby, they're going to live 80, 90 more years. I often try to put it into perspective in that when we talk about radiation increasing things like cancer risk down the road, we're talking about repetitive exposures, and it's all about the dose that you're getting. So one single head CT is not going to increase that risk greatly. likely. But if you're someone who's getting head CTs once a week for 5 years, yes, that might increase that risk. And so I think bringing in that it's kind of like a dose-dependent relationship, and that, again, if you're worried enough when you're having someone in the ICU missing something that could potentially be life-threatening, the risks of that outweigh the risks of doing a single head CT.
Tell me, does the baby get the same dose of radiation that like an adult gets when they get a head CT? Are they able to attenuate that some?
So I think it depends also where you are. Most pediatric places have low-dose CD protocols where they're actually doing lower radiation to babies and kids than they are for adults. That obviously is institution dependent, but I think a lot of pediatric institutions are doing more low-dose CT protocols.
Ilyse, another question about head CTs. What if we had EEG leads on this patient?
Yeah, good question. So this is also a little bit institution dependent. There are CT and MRI compatible EEG leads. And so it depends on where you are. Some places you have to remove the EEG leads in order to get a CT scan because they will obscure the picture because they are not CT or MRI compatible. Some places actually do have more CT and MRI compatible EEG leads where you would just need to disconnect them from the machine to transport them down, but leave the leads in place. So there is a possibility that you would not need to disconnect someone from an EEG, but I don't want that to limit anyone getting an emergent head CT. We can always reconnect people to EEG if we need to. But if there are indications for an urgent head CT, please do not let EEG limit you from doing that.
Yeah, like you could physically always do it.
Exactly.
Let's move on to case number 2 here. Ilyse, you're still on call. We've got a 16-year-old girl presenting to the emergency department with left-sided weakness that started 2 hours ago. History is notable for oral contraceptive use and 2 weeks of lower extremity pain and swelling. Physical exam is notable for left arm and hand weakness and a facial droop. So I'd love to talk about the best initial imaging strategy for this patient and how we really structure things. But before we get into this, she's coming in with sudden onset symptoms. She's in the ED. She would hopefully, in most institutions, trigger a code stroke, right? What's happening at a code stroke?
Yeah.
Or a stroke alert, whatever they are.
Yeah, I was going to say it depends on what you call it based on where you are and what your hospital calls it. But really, when we're talking about code strokes or stroke alerts, we're talking about people that are candidates for hyperacute therapy for stroke. The hyperacute therapies are TPA for thrombolysis or thrombectomy, which is the removal of a clot in a large vessel. And so those two therapies, so the thrombectomy can be done within 24 hours of last known well, and TPA can be done within 4.5 hours. So if you're in that treatment window, that would be the time to trigger a code stroke for someone with acute focal neurologic symptoms. And typically what that entails and what it is at our institution is one of our neurologists comes and examines the patient urgently and comes up with an NIH stroke scale, which goes through all different symptoms. Again, not specific for stroke. You can get a high NIH stroke scale with many different neurologic conditions, but you are trying to figure out if someone has a severe disabling deficit based on your exam and trying to figure out when their last known well was to see if they fit in the window for that hyperacute therapy.
So after you have your assessment and you get the gestalt that this patient is high risk for stroke, or at least deserves neuroimaging, what is the best strategy moving forward? What's the next step?
Yeah, so the best imaging strategy for stroke would be an MRI scan if you have it available. A lot of places, us included, do not have MRI capabilities overnight. And also some of our younger kids would require sedation for an MRI scan. So that sometimes is not feasible from a logistical standpoint. But from a pure imaging sensitivity standpoint, MRI is going to be your most sensitive image for detecting acute ischemic strokes. Most places, when MRI is not available, CT scans are going to be your next option and sometimes are your first option, or initial imaging when you have someone come in for a code stroke. Your CT scan is only about 60% sensitive for detecting acute ischemic stroke. And usually what you're looking for is actually more subtle secondary signs that there was ischemia. You're not actually going to see the hypodensity on the CT scan in this kind of early window.
Are you able to infer other signs from the CT? I imagine it's helpful to know there's not a hemorrhage. Tell me more what else the CT can offer.
Yeah, so the thing I always remind people is actually in the adult stroke world when we're doing, because most of adult stroke codes are run in CT-based imaging. And so I remind people that the majority of the time when we're making decisions about giving TPA, we're doing it based on a negative head CT. So when people say this can't be a stroke because the CT is negative, that me as a neurologist, I'm always like, no, wait, I need
deeply offended by that.
Yeah, I'm like, hold on, wait. And so in the adult stroke world, most of the time when you're giving TPA, you're looking to make sure there is not a hemorrhage. And also you're making sure that there isn't already evidence of a large territory stroke, because that might tell you the stroke is older than you think. So CT scans are not sensitive for showing strokes within the first 6 hours of onset. And so if you actually do see the stroke, you should question when their last known well is, and if this is actually an older stroke than you think, and treating them with a therapy like TPA could actually increase your risk of hemorrhagic conversion. On CT scans with large anterior vessel strokes, so like MCA being your most common, you can see some kind of subtle secondary signs like blurring of the gray-white junction. You can sometimes see some insular swelling in that area as well. Very rarely you can see what's called the hyperdense MCA sign, which is the MCA on a CT scan just looking a little bit darker, and that's showing you the actual clot in the MCA. And so these are all just secondary signs that you're looking for to infer that there is a stroke, but it's not great at detecting and showing you the actual territory of the stroke on a non-contrast head CT scan.
And then what about CT angiography? What about trying to look at the vessels that way?
Yeah. So CTA or CT angiography requires you to give contrast. Usually it requires a large bore IV, usually in the antecubital fossa, and sometimes 2 IVs just to like time the contrast. And it's actually really sensitive for detecting large vessel occlusions. So like your basilar artery, your anterior circulation, including your MCAs, is really, really sensitive at detecting a large vessel occlusion. So CTA, you can pretty definitively say if that's negative that you don't have a large vessel occlusion.
In the patient that doesn't have a recent trauma or isn't like coagulopathic, patient that I'm worried about a stroke and I'm pretty sure it's not a large hemorrhage, should I just always get a CTA with my CT head? Are there any subtleties that I need to be aware of?
I think just, again, your radiation exposure and contrast risk are probably the risks of getting CTAs. I think CTAs are helpful, again, if you're looking for more large vessel occlusion. So I think if your suspicion for a large vessel occlusion is not high, there's probably not much added value in getting a CTA with your CT head without contrast.
No, it's interesting because we gave you this patient we tried to describe a right MCA stroke, right? If you have a physical exam that's consistent and then you get the CT angiography and you don't see an occlusion, what do you think about that?
It could be that it's more distal. It's really good at imaging the more proximal vessels, but sometimes you can have clots in like the M2 or M3 branches that are like a little bit further out. It's also possible that there was a large vessel occlusion that dissipated or kind of went away on its own even before treatment. And so it might have been that you have ischemic changes in that area, but you don't have a physical clot that's present there anymore. Either it's more distal and it moved more distally, or it recanalized on its own, which definitely can happen in some scenarios.
Appreciate the high-level discussion about how we can utilize CT for these patients in detecting and managing acute ischemic stroke. Maybe let's transition to like a high-resource setting. You have access to MRIs and various types. What do you see as the best utilization there?
Yeah, I think MRI would be preferable in all stroke scenarios if possible. MRI is really good at detecting acute strokes or even hyperacute strokes that have really sudden onset. Your most sensitive imaging modality or imaging sequence is going to be your DWI sequence or your diffusion-weighted imaging. And really what that's looking at is cytotoxic edema. And what's happening is the cells are breaking apart and you're having a restricted diffusion of water into the cells because you have cytotoxic edema in that area. And so that DWI sequence is going to look bright in a hyperacute stroke. We sometimes look at it, comparing it with the ADC or the apparent diffusion coefficient. We look at them side by side and compare the two images. An acute stroke is going to look very bright on a DWI image, but look dark like a black hole on an ADC. And so comparing those two, if you see that imaging pattern in the same location, that to me is indicative of an acute stroke until proven otherwise. You also can use the FLAIR sequence, which is a T2 imaging sequence, and that can help you a little bit with timing of your stroke and the nuances of timing, because the flare does not become positive until after 6 hours. And so if you have someone who doesn't know when their last known well was of their symptom onset, which sometimes can be hard in children, and you have MRI imaging available and you have a DWI positive stroke, but it's flare negative, that might tell you that someone is actually a candidate for hyperacute therapy like TPA, because their imaging shows that it's definitely less than 6 hours old. So that can help you with both detecting stroke, but also helping to figure out the timeline of when the stroke happened as well.
Excellent.
So, we talked about all these various sequences that give you more information about the timing and the diagnosis of stroke. Can this be performed on like a fast or stroke protocol MRI, or do you need the full 45 minutes to an hour study?
Yeah. So I think the language of what you have available is important. So usually a fast MRI in most places just gives you 1 or 2 sequences that are mostly to look at the ventricle size to tell you if you have hydrocephalus. Our institution and some other places, a limited stroke protocol MRI will give you a FLAIR sequence, a DWI sequence, and an ADC sequence and a T1. And so those sequences are enough to diagnose a stroke, and oftentimes don't need sedation in those scenarios for kids because it takes closer to, like 10 or 15 minutes versus 45 minutes for the full MRI scan. And so if you do have the availability of doing a limited stroke protocol MRI, I think that would be a great option to diagnose acute stroke.
Yeah, 15 minutes is great. That's really impressive.
So is it fair to say if you had a patient who presents to a high resource setting who has concern for stroke, you would like to get that stroke protocol MRI, make a decision on hyperacute therapy or not? And then is it fair to say you probably would like a full MRI as soon as the patient's stable?
Yes. So usually we would like a full MRI at some point. And so, oftentimes people will come in and they might even be outside the hyperacute treatment window. So say they presented, a day after symptoms, we get a CT scan just to make sure there isn't a big hemorrhage or midline shift. And then we would want a follow-up MRI in the morning or the next day. The full MRI will obviously give us more details if there's any signs of inflammation or other things that can tell us a little bit about stroke etiology, or if there's other small little stroke areas, or if there's progression of the stroke that might give us some additional details. And so, yes, these are all talking about you're in the ER. This is the hyperacute therapy decisions. And then we would like full MRI sequences down the road at some point when you're able to.
One follow-up question, we've painted this case as like it's a slam dunk stroke, right? But kids really commonly don't present this clear cut. These stroke protocol MRIs, what is their diagnostic value on detecting things other than stroke? Can you rely on them at all?
You can. So they usually do include a T2 weighted sequence, which is usually where you're going to see a lot of your pathology show up. And so you should see if there are other pathologic changes. You're not giving this with contrast, so you wouldn't see if there's something like infection or other inflammatory changes. I would be wary of saying that this would rule out all other stroke mimics, but I think it does have some diagnostic value because you're getting a T2 imaging sequence that you could look if there are other pathologies that you could see that are not just stroke on that image.
Not replacing the history and physical exam, but a little helpful there.
Never replace the history and physical exam.
It can't? It can't? The bagel of truth can't?
Not in my house, no.
I think also you brought up a good point about stroke mimics. So in children, stroke mimics are probably the most common thing that we see, probably more commonly than acute strokes. And so that's also why MRI offers an advantage, because you're going to be able to see those other things that might make you think that it's a stroke versus a CT scan. You might just see a normal CT scan, and then you're waiting until the next day to figure out what the MRI shows. And so that's why doing an MRI early, if available, will probably be your best bet, because you'd be able to look at some of those stroke mimics instead, which are probably going to be more common than your large vessel strokes in children.
Before we move on, while we're talking about acute stroke, are there any top 3 things, if I'm in the call room taking this call from the ED, that you want me to make sure are happening besides the appropriate imaging sequences?
The first thing is also that someone's getting an accurate exam. So whether that's a neurologist or an ED doc, that someone is documenting what their stroke scale is and what their exam looks like, not just for treatment purposes, but also to know if their exam is progressing or changing, because sometimes people are not getting accurate neurologic exams, and then you're coming in and saying, is this a new symptom? Did they always have this gaze deviation? And it's really hard to know, do we need to re-image this person, or is this what they presented with? Also making sure that they're getting labs that are looking to see if the patient is coagulopathic. So specifically their PT and INR. But if you are considering hyperacute therapy, because if someone has a prolonged INR, that you can't treat them with TPA in that moment. So that would be an important kind of decision point. So make sure that they're getting that. The rest of kind of the stroke labs that we do as far as looking for stroke etiology, those things can be done at a later date as we're kind of working through, mostly making sure you have accurate neurologic exams, we're choosing the right imaging, and that we're making sure the patient isn't coagulopathic or having any contraindications to hyperacute therapy, like TPA are probably your most important things in the moment.
Excellent. Thank you.
Alice, I know you like puns at the end of the recordings. We always think about the CT as being the donut of truth, and donut shops are all over the place here in Dallas. I imagine in New York, why don't they call it the bagel of truth?
I am here for this.
We'll try that out next week. I'll let you know.
It's all about the water, I hear. It's all about the water, I hear.
It is it is the water. It's why they're better. It's
You can't argue with
leavening.
facts.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedcritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.